When we talk about Canadians not needing private insurance, that's not technically true. A lot of us do need and have insurance, either through work or through marriage or what have you, for all the stuff that is not part of the medical system.
Hi, and welcome to the Hi-Fi Health News Podcast. I'm Erica Grotto. Today, we're visiting our neighbor to the north, Canada, to learn about how their healthcare system differs from ours. Joining me is Dr. Christopher Labos, a cardiologist and epidemiologist based in Montreal. He's also the host of the Body of Evidence podcast and author of the book, Does Coffee Cause Cancer? And before you ask, I don't know, he wouldn't tell me. But he did tell me a lot I didn't know about life and health in Canada. You're having a heart attack, or you think you're having a heart attack. You go to the hospital. What's the process for payment, if any?
So if you have an acute life-threatening emergency, you call an ambulance to go to a hospital, you are not going to get a bill after the fact. You will have to pay for your medication afterwards when you go for the pharmacy. And so when people talk about health insurance in Canada, it's often for prescription drug coverage more than anything else. A little bit for rehab, a little bit for sort of other related services. But by and large, what we're talking about is prescription drug plans. And if you're over the age of 65, you will probably be covered by the provincial drug plan, which is present in most of the provinces. So for acute care in Canada, I think it's going to be very different than the US, where you might end up with a hospital bill at the end, whereas here you will literally not have to pay anything unless you want to order a private TV for your room or something, which of course is not really a thing anymore because now people just watch stuff on their phones.
Like, let's say you need to see a cardiologist and it's not an emergency, but you need to make an appointment. What's the average wait time, do you know, for a specialist?
Yeah. If you wanted to make an outpatient appointment, that's where things can take a while. Yeah. Because the reality is we don't have that many cardiologists. We don't have a lot of everything. And the reasons for this are largely historical. You have to go back all the way to the 1990s when governments at the time were trying to sort of get their budgets under control, and they were trying to fight deficits, which again was a fairly common feature in both Canada and the US. And so a lot of the funding was cut from the healthcare system. A lot of physicians were given early retirement. The size of medical schools were shrunk. And all of those decisions that were put into place in the 1990s ended up carrying through several decades later into the situation we are now, where a lot of people don't have a family doctor. There aren't a lot of specialists. So there is a lot of limitation in terms of personnel in the healthcare system. I will say, and not to toot my own horn, my wait time to see patients is actually pretty short. If I get a new consult, I will probably see somebody in a few weeks. But that's probably not typical for most people, especially if you want to be seen for a very, very specific problem. The wait times can be very, very long because most people are overwhelmed. A lot of older physicians are retiring, and there's nobody really there to sort of take over their patients. The old joke used to be that when you were a physician, you used to be able to sort of sell your practice. Now you can't give it away because there's nobody to take it over. And so fewer and fewer doctors here in Canada, or at least where I am in Montreal, want to sort of have their own outside of hospital practice because the hassle of maintaining that is becoming a lot for people. And most people just want to stay and do their hospital work, which is problematic because hospitals can become bottlenecks, right? Because if you're limited to seeing 20 patients per day, because at 3 p.m., that's when the administrative staff goes home, you can't actually ask them to stay longer. There's union rules, right? You can't just hire your own secretary. There's personnel issues with the hospital. So there are constraints in the hospital system which sort of limit flexibility. And all that has contributed to the fact that there are longer and longer wait times to see outpatient appointments because there isn't a glut of doctors sitting around twiddling their thumbs saying, I wonder when the next patient is going to walk through the door. So that has become a challenge and is really sort of demonstrated the discrepancy between hospital care and, outpatient out of hospital care.
That's really interesting. We have some pretty severe shortages across all specialties, across primary care, nursing, everyone. We've got shortages all over the place in healthcare. And I don't have numbers. It'd be interesting to look up kind of the shortages in Canada versus the US. But I read this morning that, and I'm sure it varies across specialty, it varies across geographic region, and all sorts of factors come into play. But average wait time to see a specialist in Canada is 27.4 weeks. In the US, it's 14 weeks. Still not great, right. But that's one area where it seems like the US might be doing a little bit better. Then
and I think
Canada.
This is, when we get into the whole debate about, private versus public medicine, the one advantage that private medicine has, if I may be permitted to philosophize a little bit, is you can expand, right? If your demand is X and you need more people to meet that demand, you will just hire more people. And whether that's administrative staff or new physicians, like you can recruit people, you can bring people in. In the public system, because of the way that our government organized system is set up, which is publicly funded, and also these are public hospitals, so they are quote unquote run by the government. They're not really run by the government. They're run by administrators that are essentially civil servants. But the point is that it's fixed, right? You can't just build a new hospital. We can, and we have done that, but it's not driven by the same sort of market demand. So the one issue to think about here in Canada is that supply doesn't grow to meet demand quickly. It will eventually, and there is sort of a growing recognition that as our population gets bigger and as our population gets older, we have to expand things like long-term care and all of that. So these discussions are happening. We're not sort of oblivious to these realities. But it doesn't match as quickly as it would in a private system where it's like, oh, we have a backlog of echocardiograms. Well, let's just go out and buy another echocardiogram machine and let's hire another technician to do more tests. So there is a great advantage to being in a market-based economy or a privatized healthcare system, whatever you want to call it, is that you can just buy more when you need it. The downside to that is that policy is inherently inflationary because the more you need, the more you spend, the more you spend, the more it costs. And then you get into a cycle. So there has to be some sort of balance there where you can expand to meet the demand, but also have some sort of control so that healthcare costs don't spiral out of control. Because otherwise, if there's no wait time for tests, and we've sort of seen this in Canada as well, the minute there's no wait time for tests, well, people start doing tests unnecessarily. I'll give you an example. And this is part of the heterogeneity of Canada because every province has its own healthcare system. We don't have one national healthcare system. It's managed separately by each province. And there are some differences between two provinces. So a very specific cardiology example between Quebec, where I am, and Ontario, which is the province next door. In Quebec, you can only do cardiac ultrasounds in hospital at accredited centers. In Ontario, you can do them even in your own clinic. And for a while, everybody had a cardiac ultrasound machine, even non-cardiologists, even people who had no business doing cardiac ultrasounds. So people were getting cardiac ultrasounds for no seemingly logical reason.
So you said each province has its own system. Does that mean if you travel to another province and something happens that your care is different or the financial aspect of your care is different?
So in theory, no. Because while each province has its own healthcare system, it's administered by the provinces. They are governed by something called the Canada Health Act, which as part of its stipulations has said that your healthcare should be transportable, meaning that it should be good anywhere in Canada. Now, I say should because there have been situations where people go with a health card, because we have our health card, right, that says with our name on it, so it's government issue ID, present their health card to the hospital that they go to. And they will say, oh, I'm from this province. So let's say you're from Quebec and you go to British Columbia, you present your health card. They'd be like, oh, this is a Quebec health card. I don't know what to do with this. If you don't live in a major urban center, because there is some paperwork that has to go around with this, it has happened where physicians are unfamiliar with the practices that are involved and be like, well, I don't know how to cover you. Pay me and get your refund back from your home province. So that has happened. But I would say those are more the exceptions than the rules. 9 of the 10 provinces in Canada have signed the reciprocity agreement where they will agree to accept other provinces' healthcare cards at face value. And so if you're a physician working in Ontario and somebody from Alberta comes to Ontario, you will not bill the government of Alberta, you will bill the government of Ontario, even though it's an Alberta patient. So there was an attempt to sort of harmonize the process. There was one holdout, which is the province of Quebec, where I am, that didn't want to be part of that agreement for a variety of technical reasons. And so you still have situations where somebody with a Quebec healthcare card will go across the country and not get covered. And then you have these conflicts.
We talk a lot in the US about having choices in healthcare. And it used to be you kind of went to your doctor, they sent you wherever they were going to send you if you needed specialist care. You relied a lot on your physicians to kind of give you direction. The tide is turning a little bit. We have a few more choices here. Do Canadians have choices about where they go for their health care?
I would say yes, in the sense that if you show up at a hospital and say, I'm sick, they can't turn you away. There has been an attempt by government to try to set up like corridors and sectors, meaning if you live in this region, go to this hospital. Because what they wanted to avoid was this sort of centripetal force in the big cities where everybody wanted to go to the major downtown university hospitals because that overwhelms the system, right? And especially if you have a non-urgent, non-complicated case, maybe you don't really need to be in a downtown university hospital. Maybe you can be treated in a peripheral center. So a lot of that was, I think, an understandable reaction trying to sort of push things out a little bit and spread the burden of disease so that you don't have all the resources in one center, treat people closer to where they are. So there is an attempt to do that. That being said, if you get in your car and show up to the emergency room of a particular hospital, they will not turn you away. If you call an ambulance, the ambulance is probably going to take you to the closest hospital. But if you say, I'm a cancer patient, I'm followed there, the ambulances do have the discretion and by and large will take you to where your main hospital file is, especially if you're followed at a particular place. So you do have choice. The thing that has become a limiting factor now is because of all the recent retirements. Because we have an aging physician population, because a lot of people have retired and not been replaced, because a lot of people dropped out during COVID. And sort of the one caveat to that is, to all this conversation, is that we would have been having a very, very different conversation 5 years ago pre-COVID. Because of COVID, a lot of people got burnt out, a lot of people took early retirement, a lot of people got sick, and a lot of people left the profession. And so there has been a real drain on resources because of the pandemic. And that has left people with not less choices, less options. Like a lot of people just don't have a family doctor anymore because a lot of them retired. And for a variety of reasons, we have made family medicine unattractive to a new generation of medical school graduates who are like, well, I don't want to do family medicine. It's not paid as well. It's a lot hard. I don't have the resources I would have. I'd rather do a specialist type practice in a hospital where I don't have a lot of these problems.
Yeah, a few weeks ago, I spoke with a primary care physician, and the way he described primary care in the US was very, very similar to what you've described in Canada. As far as physicians don't want to go into it because it doesn't pay as well. They don't have the support that they would otherwise have in a specialty. So I guess we have some similarities there.
A lot of the constraints that we have are budgetary constraints. And this is a problem because government cutbacks have allowed the growth of privatized medicine in this country. 20 years ago, there was no such thing as a private doctor. There were private doctors, but you didn't go see a private doctor, right? If you were really sick, you went to a quote unquote real doctor. But now, because a lot of people have opted out of medicine, because there is this fatigue, disillusionment, people find it hard to work within the system, COVID made everything worse. You're seeing a lot more private clinics that are saying, well, rather than waiting, why don't you come here? We'll do your cataract surgery right away. We'll do your hip surgery right away. We'll do your radiology tests immediately.
Do you have the same phenomenon there that we've had here of big business that is not in healthcare try to get into healthcare? Like Walmart had some, and I think a lot of them have pulled out. Walmart, Amazon, a lot of other big businesses have entered healthcare and looked around and went, "Wow, this is harder than we thought it was going to be," and then retreated. Do you have that happening in Canada too?
A little bit. There was actually a big story where I am in Montreal where this private company owned a bunch of medical clinics and they actually filed for bankruptcy protection, which is like shocking to me. Actually, it was even worse than that. There was this large, not private clinic, because most of the doctors, it was a private company, but all the doctors were on Medicare. So the patients didn't pay, but it was a private company that owned the building and had services. And
now, can we define Medicare?
Okay.
Because it means something different here.
That's true. All right. So we colloquially refer to Medicare as the public system. In reality, you have different provincial services. So every province runs its own healthcare system. Every province has a different agency that pays for medical care. So you as a doctor, when you see a patient, you will submit a bill, not to the patient, but to the government. In fact, this government agency, it's not really a bill. It's sort of this automated electronic database thing where you plunk in patients' information and you get paid per patient. So in Quebec, it's called RAMQ because we deal in French. So it's the Régie d'assurance médicale du Québec. In Ontario, it's called OHIP, which is the Ontario Health Insurance Plan. It's different for every province. We sort of collectively refer to it as Medicare. The difference between the US is that Medicare applies to everyone, every Canadian citizen and even permanent residents, regardless of age, as opposed to just being over the age of 65. The one sort of quirk to that is, again, Medicare, or the government drug insurance plan, typically only applies to people over the age of 65. So if you're under 65, you still have to pay for your drugs out of pocket. And you will ask, well, why that exception? There's no reason for it. It's how it was defined originally, and nobody has ever gone back to fix it. There has been an attempt in recent years to try to harmonize it, to try to bring dentistry into Medicare, because dental care was never part of Medicare, so you had to pay for that out of pocket. So there has been an attempt to sort of address what are typically seen as historical exceptions that don't make any clinical sense, because, I mean, if you need eyeglasses, why should that not be covered by Medicare? They're not, it's not an elective thing. You need to see. If you have a chipped tooth, you need to go see a dentist. So there's been a push to try to incorporate all that stuff into Medicare, but it is expensive. And so this is where the budgetary fights come in. So Medicare is what we in Canada refer to as the collective of the various healthcare systems that exist across all the provinces, which I realize is different than what it means in the US.
Yeah. Well, and you brought up dentistry. It's separate here too. It's not covered by my health insurance that I, would use if I'm sick, but I have a separate insurance for dentistry, and I have another one for my eye care. So
and that's largely what happens here. So when we talk about Canadians not needing private insurance, that's not technically true. A lot of us do need and have insurance, either through work or through marriage or what have you, for all the stuff that is not part of the medical system, which is eye care, dental care. And the reason why it was never incorporated into medical care is because when we go back historically to the inception of the Medicare system here in Canada, it began as hospital insurance. When it was started, it was basically the government saying that they were going to provide universal health insurance to one province originally for their hospital bill. So the government basically decided that it was going to be a giant HMO. And that eventually expanded to all the provinces. The federal government got involved, standardized certain things, and sort of expanded to include out-of-hospital care. But our medical system didn't sort of arrive fully formed from heaven. It was sort of built up over time. But part of the problem of that is you build on a foundation. It was all built on the conception of hospital care, which did not involve a lot of the stuff that we consider just as important, right? Like physiotherapy, like, speech pathology, like seeing a dietitian, like all of that is not part of medical care because it wasn't typically included in hospital care. And you have to pay for it out of pocket. You're seeing outside of the hospital. The weird thing is that if you need to see a physiotherapist and you see them in the hospital because you broke a hip, that's covered. But if you need to see a physiotherapist because you have some chronic condition and you're out of the hospital, that's not covered by Medicare.
Do you think most people are happy with the system, generally happy, or are there a lot of complaints like over here in the US?
I think there are a lot of complaints because people have seen a very noticeable difference between today and what the system was like even 5 years ago. And a lot of that is a question of access. They don't have a family doctor. They have to go to these like polyclinics where they're seeing a different person, and they're like, well, only show up if you're sick. You're like, well, what about preventative care? Well, so there's a lot of things about the system that people are frustrated with. But I think they are very temporal issues that have grown up because of a very, very specific problem. Well, two very specific problems, cutbacks in government funding because of deficits and COVID, which just made everything worse. So I think people are frustrated with the system. As a general rule, I would say the vast majority of Canadians like the fact that we have a public healthcare system, like the fact that they're not going to spend $100,000 if they need heart surgery, and like the fact that they don't have to worry about being financially destroyed by a healthcare bill in the same way that, we hear some people are in the US. I will tell you that there is a collective fear deeply ingrained in the Canadian psyche about traveling to the US without health insurance. Because they know you get sick in the US and you don't have health insurance, the only backup plan people have is rush to the border and hope they don't catch you and come after you with a collection agency, because we know that healthcare costs can be extreme. So getting travel insurance to go to the US is something that preoccupies everybody before they travel, because they know you need that safety net. So as a rule, I think we all like the fact that we have a public system where you are not paying to see a doctor, but there are a lot of current problems that have sprung up. And I think a lot of those current problems are going to see more and more privatized medicine come into Canada. And if you have insurance, you may end up being okay with that. I just worry about all the people who, don't have insurance.
Well, thank you so much for joining me and educating me on Canadian healthcare.
Oh, thank you for having me.
That's it for us this week. Be sure to follow Hi-Fi Health News on YouTube to get all of our content. Thanks for watching.